love the way that it looks like you have beautifully merged the world of radiology, interventional radiology, cardiology, interventional cardiology, and cardiovascular disease management in such a beautiful way, as well as brought so much innovation and expertise. I saw where you really were pivotal in bringing low radiation, lowering the exposure rates, et cetera. So I'd love to hear all about that, but mostly I want to just help everyone understand how exciting this is, like this test is now available.
Oh,
Okay.
and I'm with you 100%. I think this is the most exciting thing I've been involved with in my career. And it is a compilation of lots of different fields of research that sort of have come together at the right time. We understand the biology of atherosclerosis now, which we didn't really fully understand 10 or 15 years ago. Mm-hmm. You know, the CT scanning technology nowadays is much better, very much lower radiation doses than it was 10 or 15 years ago. So a lot happening simultaneously. Even artificial intelligence and machine learning has had big advances. And so all of those things were necessary for us to be able to do what we do currently.
Wow, very exciting. Have you been working on refining these protocols and refining the AI, et cetera, for several years? How long is this? I know it's been your life's work, I guess, but how long has this particular technology been in the?
Well, we came out of what was called the Dalio Institute at Cornell. It was a cardiovascular research institute that was very focused on using imaging to help inform prevention. And the folks at Dalio made a number of pretty significant findings in the field, but it got to a certain point where actually Ray Dalio, who was one of the main investors, asked us, you know, how does this get to patients? And well, we sort of said, well, it's research. It doesn't really get to patients. And so that's when we realized that in order to get these findings to people, you have to commercialize it so it's actually available. So that's when Cleerly was founded back in 2017. And so it's been now 4.5 or 5 years for us. We've been in commercial operations for a year and a half, going on 2 years at the end of the summer, bringing this to the public.
Wow. In the world in which I work, where people come in and they say, I've had a heart attack, and if I have another one, I'm going to lose my business, or, you know, I'm afraid I won't make it through the next one. Or I have young people who say, I saw my dad drop dead at 50, or I saw my parents or grandparents suffer with this disease. I want to do, you know, everything I can to keep from going down that path. So in my maybe somewhat skewed view of the world, and maybe it's not, maybe it's the most reality that's out there, most real perspective is everyone age 40 or 45 needs to have this test, because never before have we been able to so beautifully understand really asymptomatic or subclinical disease, and then know in a year, 2 years, 3 years, are we making headway? Are we improving?
100%. Yeah. You know, the problem is that traditional measures of heart disease risk, such as cholesterol level, hypertension, family history, work across large populations, but they don't work on the individual, right? We have seen countless people who come in who have no risk or extremely low clinical risk who have advanced atherosclerosis. And so it's really impossible or very difficult to tell what a patient's heart disease risk or burden, how much atherosclerosis they have until you actually look, because you know, if you use the traditional measures, you'll be right in a big population that you'll choose, but on an individual basis, sometimes it works and sometimes it doesn't. And that's why we still have people who come in who have sudden heart attacks, who out of the blue, they had no idea that they have heart disease. And for, you know, a majority of the people, having a heart attack is the first time that they realize they even have heart disease. So we have a failure to identify people in the public who are at risk for heart disease.
Absolutely. I just want to pause on that for a minute and reinforce that for our listeners, because far too often the first symptom that you have cardiovascular disease, you just said it. I mean, you're lucky if you get like a little chest pain episode and a great workup and you get to the cath lab and you get things fixed before they progress. But far too often it's either sudden cardiac death, or it's a heart attack, or it's a, you know, less than ideal presentation to the emergency room. And that's like, I had no idea. And sometimes it's people that you would think, because maybe you're putting them through a Reynolds or a Framingham risk score or something. And other times, like you've said, it's people that are the healthiest person on the block and everybody's shocked. It's just because they weren't given the opportunity to look and to know.
Yeah. And so now for the first time, we actually have the opportunity to really go in and look and determine what your phenotype is. And what we mean by phenotype is do you have plaque? And there's different types of plaque. And some plaques are actually relatively benign, like calcified plaque. But other plaques are the ones that really cause risk, like the low density plaque. And those are the plaques that actually cause what we call acute coronary syndromes or heart attacks. So, we can now accurately identify those, quantify them, how much do they have, and and then they can be addressed, because the really good thing about our technology has come together at the same time. But what's also happened in medicine is, instead of just having one medication for heart disease, which is statins, nowadays there's probably 10 or more medications, all of which, when used correctly, can significantly reduce someone's risk of a future heart attack. So we really have a big armamentarium of medications that are available. And in addition to, diet and exercise, and because we also know that diet and exercise and other lifestyle changes can also significantly and beneficially affect someone's atherosclerosis. So we really are armed with a lot of things to do. So the problem is not the treatment these days. The problem is the identification of the people to use this successful therapy on. So we get great tools. We just don't know who the people to use them on is.
Oh, I totally agree. I think the general public does not understand that not all plaque is the same. So number one, you need to know, do you have vascular disease, specifically coronary artery vascular disease, i.e. we're calling it plaque because most people refer to it as such. And yes or no, I have plaque or I don't. Okay. And then if you do, as you just said, what type of plaque is it? Because that's where we can really save lives. We'll never eliminate that plaque, but we can certainly stabilize it, where I've described it to my patients more like scar tissue. If you would just share with us, and particularly our patients and followers that are listening that have no medical experience, why this technology that can blow up tiny little areas of plaque so beautifully, so we can see exactly what the makeup is of that plaque, why that's so life-saving and important.
Yeah, so we sort of have three outputs that we have of our service. So we look at the coronary arteries, those are the arteries that feed the heart muscle, but the arteries that are so important if they have plaque, and if the plaque then causes an obstruction or an event. So first of all, we look for how much plaque is there, and we put that into a volume. And then we can tell you whether there's a little bit, moderate, or a lot. Soon we'll also have some population-based normals. So if you're a 50-year-old woman, and you have so much plaque, we'll be able to say you're in the 90th percentile or the 10th percentile. So you'll be able to put it in perspective to other, sex and age matched individuals. But then more importantly, we actually look at the plaque, and there's really three sort of basic types of plaque that we divide plaque into. There's calcified plaque, which you can think of as a scar. So that's plaque that no longer really metabolically active. It's a rock. It sits there. Rocks don't do very much. They just kind of sit there all the time. And so that's what if you're going to have plaque, you would prefer to have calcified plaque. But then there's non-calcified plaque and low density plaque. And the low density plaque, it has exquisite risk associated with it. Just even small amounts of plaque will increase your risk above baseline. And bigger amounts of it can, have you up to 30 times higher risk of a heart attack than somebody without a similar amount of plaque. We can identify that type of plaque. And then between those two extremes, there's what we call non-calcified plaque, which still has a fair amount of risk. And we know that once we identify it through, intervention, lifestyle changes, diet, and medication, we can actually transform those types of plaque into the calcified plaque. The plaque, it generally doesn't disappear. In some cases, we see maybe a 30% reduction in the overall volume, but sometimes we see dramatic transformation of the risky plaque into the stable plaque. And that's what ideal therapy is. It doesn't happen overnight, but generally, within a year of somebody on the right type of therapy, we can see significant changes. And sometimes we'll see 50 or 75% of that risky plaque is transformed. Sometimes we see 100% of the low density plaque, it just disappears, which is like you want to say Yahoo, because it's amazing because it has so much risk, and literally it can disappear with the right types of therapy and intervention.
Have you ever recommended, or would you ever recommend that an individual, for example, that would fall into a category such as that, quite a great amount of dangerous plaque, repeat the test before 12 months?
Yeah, that's a great question. Studies have shown, if you look at the Evaporate trial, which Matt Budoff did at UCLA, they found statistically significant plaque changes at 9 months in their study. So that would probably be the earliest. We are working with the American College of Cardiology to have some recommendations for when do you look again, because it's not just diagnosing it. What you want to do is diagnose it, put the patient on the right therapy or intervention, and then you want to check it down the road to make sure it's correct. Because just because you get on a diet or you lose weight or you're on the right medication, honestly doesn't mean that you're changing your plaque in the right way. We've certainly seen people who continue to build up their plaque during that period of time. So what you do then is you look down the road and then you change it. You might have to intensify the therapy one way or the other, and we would advocate doing that until you stabilize it. So there are some recommendations based on the stage, how much plaque there is, and it would be between 1 and 4 years of follow-up. So, you know, that someone with very little or no plaque probably doesn't need a follow-up for 4 years. Most people, it's 2 or 3 years, but occasionally someone with the highest amount of plaque, which is only about 5% of patients, we would recommend an annual look until it stabilizes, and then you can stretch it out after that.
Okay. For our colleagues that are listening, I think there's probably several that would say, like if they're in primary care or if they're in even a functional medicine or prevention focused practice, perhaps they're thinking, I hope I can find someone in my area to collaborate with ordering this test. What I'm saying when providing education for my colleagues is I think this belongs in the primary care office. I think it belongs in the nurse practitioner clinic. I think it belongs where there are people at risk. And as we've already said earlier in this conversation, that it's people in their 40s and 50s that may look just fine, but have a family history or whatever. So if you would comment on that a little bit, I think initially I would imagine it was primarily cardiologists. I know, and radiologists that have done the work and the research and partnered, you know, technology, of course, to make this happen. But now that it's so well refined, how do you see this really getting to the masses like it needs to?
No, you've hit the nail on the head. You know, cardiology has for many years been focused on the symptomatic patient with possible obstructive coronary disease. So that's when people, you know, start to experience a lot of things. And certainly once you're at that point, you need to do stress testing, you need to do a cath, et cetera. You know, nobody's going to advocate that that's a primary care patient, right? But right. The reality is the vast majority of patients who have asymptomatic coronary atherosclerosis can easily be handled by a primary care physician, right? Once you identify someone who you think may be at risk, you can image them. You know, probably 85 to 90% of those patients that we image in that situation, that is someone asymptomatic with risk, even people with early symptoms can still be handled in the primary care setting because we can prove that they don't have any obstructions. We can prove that their burden of disease is something that can be managed medically and does not require, you know, more advanced care. So because we have made that observation, we've also designed our outputs, you know, our reports to be relatively simple. You know, you get a couple of numbers, how much plaque there is that can then be put into stage 0, 1, 2, or 3. We can tell you whether there's a you know, stenosis of 50% or higher. And so it's quite clear, you know, which direction the patient needs to go in. You know, ideally there's no disease and the patient can get reassurance or maybe do guideline directed therapy for their high cholesterol if needed. The vast majority of people are in the middle. They have early atherosclerosis that's non-obstructive. That's a point that you have a great opportunity to intervene and reduce their eventual risk. And then we have that very small percentage at the end who have obstructive disease or very advanced atherosclerosis that's probably meant to go to a cardiologist. But, you know, depending on which cohort you look at, that group is only about 5 to 15% of most people who come to us.
Wow, fantastic. So it brings an entirely new level to risk stratification because really we're not risk stratifying based on risk factors. We're actually risk stratifying based on disease and the types of disease.
The risk is the atherosclerosis, right? It's like, you know, that's if we always take the cancer paradigm, right? If you have cancer risk factors, that's one thing, but once you develop the cancer, nobody anymore cares about your risk factors. They care about the cancer. How big is the cancer? Where's the cancer located? What type of cancer is it? What stage is it, right? So we want to do the exact same paradigm with atherosclerosis, right? You know, you might use risk factors to identify someone to look at, but once you define the disease, the risk is the disease expression. It's no longer the risk factors of having the disease, right? So that's one thing cardiology has failed to do, is that we're all focused on the risk factors of the disease that are population-based. The phenotypic expression of the atherosclerosis tells you the risk. And the more plaque there is, the riskier it is. The more of the low density and non-calcified plaque there is, the riskier it is. And sometimes that's very independent of the traditional risk factors that we think of.
That's for sure. And I think based on what you were saying earlier, the few people that perhaps come back and we haven't been able to stabilize that soft plaque like we want to, I think maybe it's some of those more obscure risk factors that aren't aggressively treated, like, undetected sleep disorder problems or things like that, that haven't traditionally been on our radar. They are now, certainly for us in the world of prevention, but yeah.
Yeah, then you can dig a little further, like, hey, this LDL is fine and their BMI is fine, but their plaque is still progressing. So let's dig a little deeper and see what else we can find in them.
Yeah, absolutely. And I also like what you said, because there unfortunately will always be, maybe not, maybe if we can do the work we're trying to do, we won't always need as many interventional cardiologists, but right now we need them doing what they're doing. And a great friend of mine, cardiologist, said, Gina, I love what you and others that are doing powerful prevention type of techniques are doing, because that's just not what I do. If I don't intervene today, this person will die by tomorrow. We know they're treating acute, serious, time-sensitive situations. And some of them have morphed off into doing preventive work, but for the most part, we need them highly trained with the technology that they have to save lives in the acute setting.
Yeah, 100%. In the very long run, if we're successful and we broaden the base of the pyramid and we look at lots of people earlier on, I think initially as we do that, I think the interventional cardiologists will get even busier, because we'll find more people out there that actually have advanced disease and they'll need to be treated. But after 20 years of doing that, if everybody's looked at early enough in their life and they're treated, maybe there would be less requirements for them. And I think not everybody would be happy in that situation. I mean, heart disease is still the #1 cause of death in the United States. More people die of heart disease than die of all cancers combined. And,
yes.
Not a lot of people understand that. It's almost like heart disease has bad PR, that people don't, and people even make fun of it. You go to a restaurant and they'll have a heart disease hamburger, right? Because they think it's funny that you're eating so many terrible things at one time. But the fact is 700,000 Americans die of heart disease every year, despite all of the advancements that we have in medicine and in cardiology. We fail in 700,000 people a year, which is just an incredible number.
It is an incredible number. And I would say, I'm sure you agree, that's the failures in terms of death rate. And then there's at least that many, if not many more, that are then disabled for the rest of their life, or their life is forever changed. Hopefully not disabled per se, but definitely impacted by cardiovascular disease. Fortunately, they lived, but yeah.
Yeah, 100%. We all know cardiac cripples, people who suddenly they changed their entire life because they've had a heart attack and they feel they can no longer do all these things that they love because they're afraid of having another heart attack. The emotional and physical impact of a heart attack that you survive is still considerable. So we would love to decrease all those numbers, all the deaths, all the survived MIs. We'd love to, love to get rid of them all eventually if we can. But certainly we think that we can make a significant impact by identifying people early. And again, using a lot of these really effective therapies that are now available on them at the right time.
Yes, it's a beautiful thing, because I think while it will save lives, we know that for sure by identifying early and early intervention, those individuals that you've just described, they'll get their life back. Peace of mind. This test gives peace of mind like nothing I've ever seen. It's fabulous in terms of, even if it, like your team member there, Terry Schimmel, that recorded the video and talked about when bad news is good news.
Yes.
Even if it's bad news, it's great that we found it now, not when you're in the emergency room, because now we can do something to keep you from going down that path. So yeah, I love this test for so many reasons.
Yeah, and Terry's a great example of that. He was somebody who didn't know he had heart disease. He thought he exercised on a regular basis. And, he and some of our other employees went and got a scan just because they, for many people, they want to know where they are. And then once he saw it, of course, they intervened and now, frankly, he didn't even know that he wasn't feeling well, but now he feels a ton better than he did before. His exercise tolerance is up, and some of things that he didn't even really think were symptoms. He just thought he was getting older. Suddenly now he's feeling better, and his exercise capacity has increased, et cetera. He's a great success story for this.
Wow, that's fantastic. And I do get, his little bit of hesitancy, like when he was talking to his wife about, well, whatever we find, it's whatever we find. And I've just bebopped in there to get mine, because anytime I recommend something to patients, I try to be the first one to sign up to get it myself, so that I know what the experience is like. And because I don't want to recommend anything that I wouldn't do myself. And yet, as I was telling Blake, then I sat in the parking lot before I went in, and I'm like, you know what? I could have a widowmaker. I could have a left main. I've never had my coronary arteries look like. It does give you a little pause. And I'm like, I could be meeting with the cardiologist tomorrow when we get the results back. So it does give you stop and think for a minute about, wow, the significance of what you're getting ready to find out. But Terry's a perfect example of, even when you get bad news, it's great that you found it out.
Yeah, because regardless of what the news is, we are prepared to treat it, right? If you have nothing, that's great news. If you have, mild or moderate disease, we can be treated with a lot of medicines. If you have more advanced disease, we have great therapies out there, interventional therapies for them. So again, as I said before, the problem is not therapy and intervention. The problem is identifying the people who need it. And that's really where we have had an issue for many years.
Yeah. Wow. Really, in one sense, I hadn't thought about that. It's a beautiful thing that area of research and clinical application and technology has preceded Cleerly AI, because we just haven't had a great way to track the disease. But now that we have Cleerly AI, we can really track our interventions.
Yeah. If the only thing we had available was statin medications, and we would just put everybody on a statin and be done with it. But now we can, if you are on a statin, and one thing we have found too is that there's a lot of resistance to taking medication. People don't want to take it if they don't want to. Some of the medications have some mild side effects that are a little bit of a hassle, but we have found when patients actually look at the images that we provide to them, they can see exactly their own plaque and where it is, how much it is, and what type it is. And we have found that can be very motivating for patients to say, yes, hey, now I understand why I need to lose weight, exercise more, or be put on a medication. And we also know that they will stay on it for a longer period of time, right? And so instead of just taking it for 3 months and then not refilling their prescription if they're on a medication, you can put those pictures on your refrigerator or on your iPhone someplace and take a look at them periodically to say, hey, I'm doing this because this is in my body. And then a year or 2 or 3 years later, you can get another scan and say, hey, look, I did this. My plaque burden is down. I've transformed my plaque from dangerous plaque into more stable plaque. And those are, I think, from the patient's perspective, it can be very satisfying, very motivating to make informed decisions in their therapy, and to also understand where they're being successful.
Oh, I agree. Absolutely. I think that's a great idea. Put it on your refrigerator or your bathroom mirror or whatever you need to do as a reminder every day, because, we've talked to patients a lot about, and the general public a lot about, how all we have had before this to track is your waist size getting smaller? Is your blood pressure getting lower? Are your lipid numbers looking better? All of these things. And perhaps is your sleep study getting better? Like we mentioned earlier, if we're finding an airway or sleep disordered breathing problem, etc. But all of that really are the risk factors, and it's external. But every year or every 3 years, whenever we're getting a follow-up, to now be able to see what's going on the inside, incredible.
Yeah, no, absolutely. And then, if you need to change your therapy at that time, that's an opportunity. You're making an informed decision. It's not random. And if you change it, or if you're lucky enough, you can even de-intensify therapy at that point. If you've headed in the right direction and you've converted some dangerous plaque into stable plaque, it may be that you can, lower or reduce whatever therapy you're on.
Mm-hmm. Yes, that's exciting as well, right? Because, people, if they are resistant to statins, there's certainly resistance to high dose statins, which have their place. But yet, if we see that we've really made headway, then perhaps we could lower a little bit, or whatever the wise thing is to do. But you're right, we want to minimize the use of things that we can, things like that, but we want to maximize their use to our potential, again, to save lives.
You want to maximize their use in the patients that need it. And if you look at the current system it doesn't really identify all of the people who need it. And some people wind up getting medication who may not need it or other therapies.